every medical provider has a case that we still think about at night. Not because we were careless, not because we weren't trying to be perfect, but because that medical case revealed just how impossible it can be to provide perfect care in our jobs. Today, I'm going to share with you one of my cases, and it took me years to understand what this really meant for me, for my patients, and for how we talk about medical error and system failures in healthcare. I'm Dr. Goodwin. I'm a family medicine physician, and in this channel, we talk about all of the issues that clinicians face in healthcare and things that you can do as a patient in order to improve your medical care. Before I tell this story, I want to be really clear about something. I am not sharing this to shame myself. I'm not sharing it to blame any other clinicians, and I'm definitely not sharing it to frighten patients or to make you think that something bad is going to happen to you if you seek medical care. I'm sharing this story when I made a mistake and missed a diagnosis because medical providers, especially in primary care, carry an enormous emotional weight, and we carry it silently. We generally are not given the space or the time to talk about it. And oftentimes we're afraid to talk about it, afraid of getting sued, afraid of getting judged by our partners or other medical providers. But if we want healthcare to get safer for clinicians and for patients, we have to start talking about these stories. We have to start having these conversations about what actually happens inside our medical system. All right, on to the story. Years ago, I was practicing in a rural clinic and I was seeing 26 patients a day, which is quite a lot. There are definitely doctors who see more, but for me, that was a lot. That was 15-minute appointments, and I was doing chronic disease management, which means high blood pressure, high cholesterol, diabetes, heart failure, plus whatever kind of acute crisis they were having that day, like back pain or shoulder pain, plus managing their medications and balancing their insurance requirements and updating their preventative care to make sure that they were up to date on everything. And most of the time we do all of that in that same 15-minute visit. When you're working in primary care, especially in rural areas, oftentimes there are not enough clinicians, there are not enough specialists to refer to, there are not enough appointment slots, and there is never enough time in your day to get to everything that needs to get taken care of. Some days I was managing hospital level acuity in the outpatient office simply because patients couldn't get into the ER. There were no open inpatient beds. And oftentimes I manage specialist care because the patient just can't drive 2 to 4 hours to see the specialist, and we don't have oftentimes slots available within 6 months, sometimes to a year in our particular area. And this is not rare. This is not uncommon. I'm sure many of you are nodding along with me. This is very normal in rural America. So this is the environment that I was in when I saw this particular patient. They had, of course, what I like to call the trifecta: high blood pressure, high cholesterol, diabetes, and congestive heart failure on top of it. And cardiology, unfortunately, couldn't see him for at least 6 months. And so I was managing the congestive heart failure, and he didn't have a history of any complications associated with heart failure. So no vascular disease, no family history or personal history of lymphedema, and he didn't really have any red flags in his chart. But he did come in to see me with rapidly worsening leg swelling and sudden weight gain. His blood pressure was normal. He wasn't having any respiratory distress, which means he wasn't having any shortness of breath or trouble lying down flat. Oftentimes patients with congestive heart failure have difficulty lying flat. They get very short of breath. And so everything about his presentation looked like some mild fluid retention from congestive heart failure. So I did what is very standard for us to do for that. I increased his diuretic, and then I said, follow up with me next week. And I had asked my staff previously to hold some appointments during my week or during my day for close follow-ups like this so that I can manage my patients who are having more urgent issues. But unfortunately, in an overwhelmed system, holding patient slots is aspirational. We try, and it almost never happens. And so by the end of that day, I think even by the time he got to the front desk, every opening for next week had been completely filled. Even the ones that I had said, please hold this just in case we need the slot open. And unfortunately, I did not see him again before he landed in the hospital. And that particular leg swelling actually was not coming from heart failure. It was lymphedema. It's a more uncommon cause of swelling in the legs bilaterally. So normally we look for either peripheral arterial disease or venous stasis disease, both of which can cause swelling and discoloration on the skin and issues. We see those more commonly in our heart failure patients. Those are the patterns that we're trained to watch for. But this patient actually was having fluid draining from his lymph nodes into the legs, which meant that the diuretics, which remove fluid from your blood vessels, actually dehydrated him. So he got what we call intravascular depletion, which meant that he had extra fluid in what we call third spaces in the soft tissues of his body, but in his blood vessels where you're actually carrying the oxygen to your tissues, he was actually very dehydrated. And so his blood pressure dropped, he got dizzy, they went to the emergency room, and he was actually hospitalized to get some IV fluids to put that fluid back in his body. He did finally get in to see the cardiologist because, of course, now he had been in the hospital, and his cardiologist told him that I was a bad doctor and it was my fault and I should have caught it. So the patient was very upset with me, and I apologized, of course, and unfortunately he didn't trust me as much as I would like after that. I always apologize, but sometimes patients really appreciate that and sometimes they don't. And for a very long time, I blamed myself. Years. I would replay the visit in my mind. I was thinking through the clinical details and the assumptions that I made, and every moment that I might have missed something. Like, hindsight is always our most perfect diagnostic tool. You look back through time and you can always figure out what was going on, but none of us have access to that in real time. And the reason why I share this story is because I want to say that we medical providers are not robots. We don't walk out of exam rooms unaffected. We grieve, we worry, we question, and we really feel guilty and ashamed whenever we make a mistake. And we carry cases like this for years. So I had to really work through this in my own life, and I had to really stop and say, I should have taken more time to make sure that I had the accurate and correct diagnosis here. But when we see medical error, most of the time it is not because one clinician has failed. It is because we are working in a system that is actually designed to make failure inevitable. Because whenever you combine too many patients with too little time and too much complexity and fragmented care with no access to specialists or other medical providers to get a second opinion, and you are chronically understaffed, you are going to create an environment where even perfectly excellent clinicians will eventually miss something. Not because we're negligent, but just because we're human. I also really had to realize that I wasn't alone. That everyone has made a mistake at some point in time or another, and it has absolutely haunted them. And that we all replay cases in our mind, and we don't do it because we are incompetent. We do it because we're really worried that we're incompetent, but actually we are replaying things in our mind because we care and we want to make sure that we don't make the same mistakes or miss something in the future. We want to do more than our medical system allows for. And we see the patients, the humans in front of us that are impacted by this. And we are just haunted by the mistakes that we make, the limitations of the system that we have to work in. And every clinician has a case like this. Some people have many of them. And reflection is very healthy, but self-punishment with guilt and shame is not. And there is unfortunately no training in our medical system to help us differentiate the two of them. So, we do absolutely talk about what we call preventable medical error. When we're in medical school, we're in residency, we get quite a lot of training about it. And we talk about something called the Swiss cheese model, which is that medical errors are generally system errors, not individual failures. So individual mistakes absolutely happen, but the overwhelming majority come in environments where information is fragmented and not presented in a way that makes sense to someone. You don't have enough time, you don't have enough staff, your workloads can be overloaded, and communication between medical providers or between providers and patients can be very chaotic. And so what happens is you think about a piece of Swiss cheese that has a bunch of holes in it. Well, if you had that up against a block of cheese with no holes, you can miss something and it's going to get caught. But if you have a lot of slices of Swiss cheese where all of them have holes, eventually those holes are going to line up, and those mistakes line up until you actually have an error that makes it all the way through the system. and can actually harm a patient. So healthcare safety does a lot of research on this. We have entire departments that are dedicated to quality improvement, patient safety, risk management, something that we call root cause analysis, which is trying to get down to the actual one thing that caused the error, and human factors engineering, where we actually change our physical medical equipment to account for people being human and making mistakes. So all of these teams exist because healthcare is an incredibly complex, high-risk environment, and because systems design can predict patient safety and patient health outcomes far more reliably than training individual performance. There are great examples of this. One of them is that there is some patient equipment that was constantly getting plugged into the wrong place in the wall, and the company actually changed the design of the plug so that it didn't fit into our regular outlets and it only fit into the ones that it was supposed to be plugged into. This means that someone who is the tail end of a 12-hour shift at 5 o'clock in the morning with a terrible migraine physically cannot make that mistake. They cannot make that error. That's the kind of thing that I'm talking about, how we try to change our environment to make it so that you cannot make mistakes. And we do this with IV lines and other things like that, plugging into pumps, where we make it so that the lines physically cannot be plugged into the wrong equipment. And that really helps us make sure that we don't make preventable medical errors. So, is this getting better? We have had, unfortunately, quite a lot of studies from the National Health and Safety Committee that show that there are somewhere between 50 to 90,000 deaths every single year that are caused by preventable medical errors. And we have invested billions of dollars across the United States healthcare system to try to prevent that. A question that we keep looking at as we're looking at patient safety, is this getting better? And it is. We have made some very meaningful improvements, but of course it's not getting better fast enough. Quality improvement and risk analysis teams have made very meaningful improvements in medication safety, having the pharmacists and the nurses double check the medications and the orders. Infection prevention, we have nurses in the hospital now whose entire job is to just watch for possibility of infections, and communication during care transitions. There has been quite a lot of training in the past few years about how we communicate between medical providers who are going home from the hospital at the end of the day and medical providers who are coming on shift, but then also how we communicate in between when the patient leaves the hospital, the medical provider in the hospital, with the patient's primary care doctor. And we've passed some really amazing laws about getting your charts closed on time and making sure that you have them available to the primary care doctor. And those are all helping. But the foundational pressures, which is time scarcity, staffing shortages, and rising patient complexity, because medical care is getting more complex every year, that is continuing to undermine our progress. But I want to point out again that we're not failing at this because we don't care. We're failing at it because the load, how many patients we have, and the medical complexity has exceeded our healthcare system's capacity to manage it well. Okay, talk a little bit about risk management, which is a department of the hospital that investigates medical errors. So let's say that the patient gets the wrong dose of medication or there is the wrong kind of procedure done. This would be the department that would meet with the patient, meet with the family, talk with the nurse, talk with the medical provider, and see what happened, who is at fault, and what can we do to prevent this from happening in the future. And risk management often sounds like a punitive department or a department that's just set out to punish people, but that is not actually its primary role. A really good risk management team at a hospital aims to understand what happened, why it happened. They're aiming to protect patients from future harm, protect clinicians from receiving unfair blame, and identify the system vulnerabilities. And they really support communication with the patients and families through any kind of issue. And so a good risk management department is asking questions like, was an individual lapse that can be improved with better training? Is it predictable based on workflow? Do we need to change the way that we do work in the hospital? Was there a missed communication point? And was the clinician, was the medical provider, the nurse, were they set up to succeed? Their goal is not to punish anyone. Their goal is to improve safety. And oftentimes they end up validating what clinicians already feel, which is that we were working under really difficult conditions. So if you are a medical provider and you've believed that something has gone wrong, here are the steps that will protect you and protect your patients. First of all, do not isolate yourself because shame thrives in silence. You want to tell your colleague, tell your superior, tell the risk management department early and get people involved. And document your clinical reasoning. So not just what you did, but why you did. Because when we're looking into medical error, the context and the information that you were working with at the time really matters. Make sure that you participate in the review process. Risk management is not there to punish you. They're not there to catch you out doing something wrong. They're designed to understand the conditions surrounding the event. And separate harm from error. One of the legal distinctions is that if you made an error but the patient was not harmed, they actually cannot sue. So if you have an error, that's completely separate from if you have an error that leads to the patient actually being harmed. Bad outcomes are not always caused by mistakes. And mistakes do not always cause harm. So that's a really important thing to remember. And then, of course, like I already said, 2020 hindsight is absolutely perfect. We always can tell when we look back what we should have done, but we don't have it at the time. And so have grace for yourself and make sure that you are reaching out to talk to someone supportive for you, whether you have a therapist or a counselor or a chaplain, someone to tell what's going on and get yourself emotional support through this process. Now let's talk a little bit about what to do if you are a patient and a medical error has occurred. So you absolutely deserve clarity, you deserve transparency, and you deserve safe, respectful pathways to voice your concerns. So here's what will help you. First of all, please document everything. The dates, the symptoms that you had, the messages that you received. Print them out if you got them from your online portal. The medications that you have, the doses, the instructions that you were given. The more facts that we have, the more clarity that we have, and the more that we can figure out whether or not a mistake has occurred. Secondly, please bring forward your concerns as early as possible. Don't wait a week, a month, or even a year after the event has happened. We want that information early so that we can make a difference and make a change as quickly as possible if we need to. Ask questions without apologizing for it. If you feel like something isn't adding up, say something. Say, hey, I don't understand what we're supposed to be doing here. This feels like it's causing a problem. I'm really concerned about this. Can we talk through this again together? That is completely appropriate. I very rarely see any medical providers who have any issues with that. And then use a patient's relation or an omnibud's office. If you are in the hospital, there is an entire department that will come and talk to you if you are having difficulty with your medical providers or your nurses. And they are there to facilitate your conversations, to clarify communications with medical providers, to review your care concerns and support safety. So if you need to, please ask someone for help. So if you speak up for yourself and document everything, does that reduce the risk of medical error? And the answer is absolutely yes. When patients speak up early, error detection improves significantly. My favorite patients when I'm working in the hospital are the ones who have either a notebook themselves or they have a loved one who has a notebook right at the bedside and they are writing everything down. They are double checking everything. This helps the most if you are in the hospital for more than a week or two, because we are switching medical providers. You're seeing a new doctor probably every single week or so. And if you can write down, hey, 3 weeks ago, this doctor tried this medication and we had this adverse effect, even though we shouldn't miss that in the medical record system, we are also documenting everything. Sometimes it still gets missed. I've definitely seen it. And so the patients who are saying, or the patient's family member who is saying, hey, we've already tried this, or hey, the patient had a reaction to this, or hey, this is the doses of the medication that we've been giving this entire hospital stay, the whole 6 weeks that they've been there, that absolutely improves care. That improves our medication accuracy. It improves our care coordination. It improves early recognition of any concerning symptoms that we might find. So you are definitely not a burden. If you are writing every tiny little thing down, you are our safety partners, and we really appreciate that. So if you are a medical provider who is carrying a case like this, please hear me. The fact that you still think about that patient is not proof of failure. It's proof that you still care. It is proof of your compassion. It is proof of your humanity. And it is proof that you entered this field for the right reasons, because you wanted to take care of people. This system absolutely asks us to be superhuman and then punishes us when we can't be. But you are not alone. Every medical provider carries a story like this, and I think it's time that we talk about them. So if you want to share your story either in the comments or privately, anonymously, message me on LinkedIn or my email. I am definitely here. And if this resonated with you, I encourage you to watch my last video, which is entitled Be Perfect or Someone Dies, the first lesson that medical school teaches you, because this gives context for why these cases hurt us so deeply. And if this has been interesting for you, hit subscribe and follow along, because we are going to have a lot more conversations like this. Thank you so much for being here with me today. Take good care of yourself today, because no one cares about your health as much as you do.